Hello everyone, I am Sakthivarsan, working as a tutor in Department of Physician Associate in Yenepoya School of Allied Health Science, Yenepoya deemed to be university. Today I am going to present the topic about Guillain-Barré Syndrome, also pronounced as Guillain-Barré Syndrome. So specific learning objectives. At the end of the session, you will be able to describe Guillain-Barré Syndrome, classify the subtypes along with features and pathology, list out the etiology, explain in detail about investigations and managements. Moving on to introduction, Guillain-Barré syndrome is a rare but serious post-infectious immune-mediated neuropathy. It results from the autoimmune destruction of nerves in the peripheral nervous system. The hallmark is an acute paralysis evolving over days or weeks, loss of tendon reflexes. The most common variant is an acute inflammatory demyelinating polyneuropathy, shortly known as AIDP. About 2/3 of those who are having AIDP have a prior history of infection. The other common variant of GBS is Miller-Fisher syndrome, shortly known as MFS. The patient usually presents as rapidly evolving ataxia and areflexia of limbs with or without weakness, and ophthalmoplegia, often with pupillary paralysis. Etiology of GBS are approximately 70% of cases of GBS occur 1 to 3 weeks after an acute infectious process. Usually, it will be result from respiratory or gastrointestinal infections. Sometimes it is preceded by infection or reinfection with Campylobacter jejuni. Usually, this bacterium will found in the GBS cases. People who are eating a raw or uncooked meat who can have the high risk of getting this GBS from this Campylobacter jejuni. During the Zika virus outbreak, many GBS cases were described. Moving on to subtypes or variants of the GBS, the first subtype is known as acute inflammatory demyelinating polyneuropathy, shortly known as AIDP. Features of this first subtype is adults affected more than children. 90% of cases were seen in Western world. Recovery will be very rapid. Anti-GM1 antibodies are seen in this subtype. Electrodiagnosis of this subtype is demyelination. Pathology, first attack on Schwann cells, widespread of myelin damage, macrophage and lymphocytic infiltration get activated, variable secondary axonal damage. Moving on to second subtype of GBS, which is known as acute motor axonal neuropathy, shortly known as AMAN. Usually, children and young adults are getting affected. It is most prevalent in China and Mexico, maybe seasonal. Recovery will be very rapid in this subtype. Anti-GD1A antibodies are seen. Electrodiagnosis of this subtype is axonal. Pathology of this subtype, first attack at motor nodes of Ranvier, macrophages and lymphocytes are activated. Frequent periaxonal macrophages are also activated. Extent of axonal damage highly variable. Moving on to third subtype, which is known as acute motor sensory axonal neuropathy, AMSAN. Features of this third subtype is mostly adults getting affected. It is very uncommon. Recovery will be very slow, often it is incompleted. Closely related to AMAN, which is known as the second subtype of GBS. Electrodiagnosis is axonal. And moving on to pathology of third subtype, it is same as AMAN, which is the second subtype, but also affects sensory nerves and roots. Axonal damage usually severe in this third subtype. Moving on to the fourth subtype, which is known as Miller-Fisher syndrome, shortly known as MFS. Usually adults and children are getting affected, and this subtype is very uncommon. Those who are having MFS will present with ophthalmoplegia and ataxia, which is known as loss of imbalance and coordination in muscle, and areflexia, where the deep tendon reflexes will get absent. Anti-GQ1B antibodies are seen in this subtype. Electrodiagnosis of this fourth subtype is demyelination, and pathology, few cases were examined and it is resemble the first subtype, which is known as AIDP. Moving on to clinical features, the patient will usually present with rapidly evolving areflexic motor paralysis with or without sensory disturbances. Patient will have the distal paresthesia, where the paresthesia will start from the lower extremities, and third one is ascending paralysis. Usually the paralysis will start from the lower limb, later it will be transmit to the upper area of the body and also known as rubbery legs. Patient will also have the sensation like tingling dysthesias or numbness and weakness in the extremities. Moving on to further clinical features, facial diaparesis is present in 50% of cases. Patient will also have facial and bulbar weakness where the patient will have the difficulty in speaking and to form the words. Weakness progress over a maximum of 4 weeks. Patient will also have the pain in the regions like neck, shoulder, back and spine. Deep tendon reflexes attenuate or disappear. The other clinical features of GBS are bladder dysfunction may occur in severe cases. The patient will also have dysphagia because of the involvement of nerves like vagus nerve and glossopharyngeal. Respiratory failure can develop within hours. Those who are having a Miller-Fisher syndrome, the patient usually present with internal and external ophthalmoplegia, ataxia and areflexia. Moving on to the investigations of GBS, first we can see the history of patient. GBS often presents within 1 to 6 weeks of antecedent illness. Other antecedent events that have been linked with GBS include vaccination. For example, in 1976, strain of swine flu vaccine has developed this GBS cases. Other antecedent events like surgery, trauma or other infections. Moving on to next investigations, the CSF protein is raised about 1 to 10 gram per liter, 100 to 1000 milligram per deciliter, but may be normal in the first 10 days. There is usually no increase in CSF white blood cells. Electromyography and nerve conduction studies are helpful in differentiating the GBS from the other nervous related disorders. In electrophysiological study, we can see the changes like conduction block and multifocal motor slowing, sometimes most evident proximally as delayed F waves. MRI spine will reveal the enhancement of the nerve roots. And moving on to the management of GBS, active treatment with plasma exchange or intravenous immunoglobulin therapy are the common treatment which can be useful in the GBS patient. In severe GBS, both intravenous immunoglobulin, shortly known as IVIG, and plasma exchange started within 2 weeks. IVIG is administered as 5 daily infusions for a total dose of 2 gram per kg body weight. A course of plasmapheresis usually consists of 40 to 50 ml per kg. Plasma exchange 4 to 5 times over a week can be given to the patients who are having GBS. Moving on to supportive care, along with management, regular monitoring of respiratory function, heart rhythm and blood pressure, nutrition, deep vein thrombosis, prophylaxis and cardiovascular status are important. If the patient is involving respiratory or respiratory failure along with GBS, yearly consideration of tracheostomy and chest physiotherapy is mandatory. Supportive measures to prevent pressure sores and deep venous thrombosis are essential. Moving on to differential diagnosis of GBS, first one is acute myelopathies. The patient will present with prolonged back pain and sphincter disturbances. Second one is diphtheria. The organism which is causing diphtheria, if it enters into the nervous or blood system, it will create the neurological symptoms which will reflect the GBS symptoms. The third one is porphyria. Patient will have abdominal pain, seizures, psychosis. Fourth one is Lyme polyradiculitis and other tick-borne paralysis. Next one is poliomyelitis. Patient present with fever and meningismus are common. The last one is myasthenia gravis and other botulism disorders where the pupillary reactivity will last yearly. And moving on to complications of GBS, death usually results from secondary pulmonary complication. Severe proximal motor and sensory axonal damage is present. Bulbar palsies, breathing difficulties, pressure sores are most common in the post-GBS patients. Moving on to prognosis of GBS, after the acute phase of the illness, Guillain-Barré syndrome patients tend to do well. More than 80% achieve independent ambulation after 6 months. Mortality during the acute case of the illness is less than 5%. Moving on to the summary of this presentation, GBS is an autoimmune condition where the own immune system will affect the peripheral nervous system. GBS have 4 subtypes or variants. Subtypes are differentiated from features and antibodies. Investigations of GBS are history, CSF analysis and nerve conduction study. Treatments are IVIG and plasma exchange. And these are my reference. Thank you.